Okay, let's dive straight into this explainer. Today, we're approaching our microbiology breakdown on meningitis, kind of like a biological mystery. We're going to identify the microscopic threat, analyze the clinical evidence, and deploy some highly targeted countermeasures. So if you want a structured, high-yield look at the etiologies, treatments, and prophylaxis for meningitis, well, you're in exactly the right place.
Here's our quick roadmap for today. We'll be hitting 6 key areas, starting from defining the microbial threat, moving through the clinical presentation, decoding the CSF, looking at targeted treatments, prevention, and finally, tackling those tricky, atypical, and immunocompromised cases.
All right, let's kick things off with Section 1, defining the microbial threat.
Now, the crucial thing to remember here is the definition itself. Meningitis isn't just some general brain infection. It's an inflammatory response that is strictly localized to the brain's meninges, those protective layers surrounding your central nervous system, and it's specifically driven by an invading microbial agent.
And when we look at the culprits, the etiology is neatly broken down into bacterial, viral, fungal, and parasitic branches. But notice how the bacterial pathogens are actually stratified by age? It's pretty fascinating. Neonates up to 28 days are primarily threatened by E. coli and Group B strep. Then, preschool kids under 5. They're largely targeted by H. influenzae. As we move into adulthood, N. meningitis, or meningococcus, takes the lead. And for folks over 60, pneumococcus really becomes the primary culprit. It's basically a highly organized microbial division of labor.
Now, the biology of one specific chronic pathogen totally dictates our clinical timeline here. Mycobacterium tuberculosis is notorious for its absolutely glacial doubling time of 18 hours. I mean, compared to standard bacteria that double in just 1 to 2 hours, TB moves incredibly slowly. And this perfectly explains why we have to wait a grueling 6 to 8 weeks just for TB culture results to come back. Obviously, we simply can't wait for that culture to actually start treatment.
Moving right along to Section 2, clinical presentation and the triad.
In the clinic, you absolutely must anchor your initial diagnosis on this classic meningitic triad: headache, neck stiffness, and fever. When the meninges get inflamed and start swelling against the skull, these 3 major red flags appear. On top of that, you confirm your suspicions with signs of meningital irritation, or SOMI, by eliciting physical responses like Kernig's and Brudzinski's signs, which basically involve pain or involuntary reflexes when you move the patient's legs or neck. You'll immediately know if those meningeal layers are compromised.
But hey, not all meningitis presents at the exact same speed. Just look at the stark contrast in the pacing mapped out here. Acute bacterial meningitis strikes suddenly, right? We're talking high heat, a high-grade fever spiking over 101 degrees Fahrenheit. But in complete contrast, TB meningitis creeps in insidiously, presenting over weeks with a low-grade fever under 101. That timeline alone is a massive diagnostic clue for us.
And we definitely have to highlight the catastrophic worst-case scenario here. This high-yield clinical pearl outlines Waterhouse-Friderichsen syndrome, which is primarily tied to meningococcal infections. What happens is it causes profound bleeding directly into the adrenal gland. The result? A sudden precipitous drop in aldosterone, plunging the patient straight into irreversible septic shock. Left untreated, we're talking about a 100% mortality rate. It just goes to show how rapidly acute bacterial meningitis can escalate into a total systemic collapse.
Okay, let's look at the evidence in Section 3, decoding the CSF examination.
By running a lumbar puncture, we can essentially look directly at the microscopic battlefield. A purulent, turbid appearance with a massive spike in neutrophils that points straight to acute bacteria. A classic fibrin web formation hints heavily at TB. Meanwhile, clear fluid with lymphocytosis, so an elevation in lymphocytes, strongly suggests a viral culprit. The cytology literally tells the whole story if you know how to read it.
And nestled within that biochemistry is an absolute golden rule in microbiology. Bacteria eat sugar, viruses don't. Because of this, assessing the glucose levels in the CSF is absolutely critical. But here's the catch. A CSF glucose reading is totally useless in a vacuum. Comparing that CSF glucose to a simultaneous blood sugar level is non-negotiable if you want an accurate diagnosis. So always send the blood sugar level alongside the CSF.
Now, to get those perfect results, you need a flawless collection technique. You've got to follow this strict lumbar puncture sequence. First, you extract 3 separate 3 to 5 milliliter samples. The first 2 go immediately over to cytology and biochemistry to check cell counts and glucose. Then, you strictly reserve that 3rd sample for your definitive targeted tests, stuff like a bacterial culture, a viral PCR, or a Zeal-Nielsen stain for TB. Doing it in this exact sequence ensures your final, most important diagnostic sample is completely uncontaminated.
So we've cracked the code. Now it's time for Section 4, Targeted Treatment Protocols.
Remember, time is brain tissue. Before you even think about touching a spinal needle, you have to follow these life-saving triage steps. Step 1, administer injectable benzyl penicillin to start fighting the infection right away. Seriously, do not delay antibiotics for imaging. Step 2, get a plain CT of the brain. You absolutely must rule out raised intracranial pressure before doing an LP, otherwise you risk a fatal brain herniation. Only after that CT clears you do you proceed to Step 3, the actual lumbar puncture.
While we're waiting around for those 72-hour culture reports to come back, we have to jumpstart empiric antibiotic therapy. And age drastically changes your coverage strategy here. For patients under 55, injectable ceftriaxone or cefotaxime is your drug of choice. But look at the patients over 55. They require the baseline ceftriaxone plus injectable ampicillin. That addition is absolutely crucial to cover for specific resilient strains that tend to prey on older immune systems. Now, if our labs happen to point to a viral threat, like HSV, for example, we treat that with acyclovir for 14 days. But this comes with a massive warning attached. Acyclovir is a crystalline drug. If you don't push fluids aggressively, those crystals will literally get stuck in the patient's renal tubules, causing severe crystal nephropathy. You really must ensure the patient is getting 3 to 4 liters of IV fluids a day to protect their kidneys while the drug clears the virus.
We go through all these rigorous protocols because the stakes honestly couldn't be higher. Even with optimal rapid treatment for acute bacterial meningitis, we are still looking at a staggering 40% mortality rate. And of the 60% who do manage to survive, 40% of them will suffer from lifelong morbidities, including things like paralysis and severe weakness. It's really serious stuff.
Because of those grim numbers, let's pivot to Section 5, Prevention and Prophylaxis.
You basically have 2 distinct prophylactic shields here against threats like meningococcus. The first one is active immunization, so the vaccine. This builds antibodies over about 2 weeks and is ideal for post-splenectomy patients, the immunocompromised, or folks attending massive gatherings like Hajj. The second shield is post-exposure prophylaxis. If you've been in direct contact with an infected patient, there's obviously no time for a vaccine to kick in. You need immediate chemoprophylaxis, meaning rapid intervention with oral rifampicin or a single dose of ciprofloxacin to kill that pathogen before it even has a chance to replicate. Finally, let's wrap up with Section 6, atypical and immunocompromised cases.
Let's quickly run a differential diagnosis for an immunocompromised patient presenting with a fever and a headache. In these cases, we're usually weighing 2 major opportunistic threats: a protozoan parasite called Toxoplasma gondii and a fungus known as Cryptococcus neoformans. Now, despite having pretty similar initial presentations, their diagnostic markers and treatments are just worlds apart. Cerebral toxoplasmosis leaves these hallmark ring-enhancing lesions, basically brain calcifications that are visible on a plain CT scan, and it's treated with IV cotrimoxazole. Cryptococcus, on the other hand, reveals its structural fungal hyphae when the CSF is prepped with an Indian ink stain by a mycologist. And naturally, it requires a completely different chemical weapon, the incredibly potent antifungal amphotericin B. We've seen the incredible clinical detective work it takes to classify, diagnose, and treat the myriad causes of meningitis. But this is an ongoing biological arms race, isn't it? Which leaves us with a critical question to ponder. As bacterial strains grow increasingly resistant and viral threats continue to evolve, are our current prophylactic measures and empiric antibiotic protocols truly enough to stop the next major outbreak from breaching the meninges? Thank you so much for exploring the science with me today, and keep questioning the evidence.